Okay, so today, this week's seminar will contain a guest speaker. We have Andara, and then we will be going over hernia repairs, and then I'll be talking about a case study known as Mary, and then we'll be doing interview like university interview tips, and then we'll be talking a little bit more about breast cancer because it is Breast Cancer Awareness Month. All right, can I please hand over to Andara for her guest speaker event?
Hi everyone, thank you for joining. My name is Antara and I'm finally a medical student at Holyoke Medical School. And I'll be sharing my journey through all 5 years of medical school and also talk a bit about my elective experience that I did abroad. So hopefully by the end, you'll have a clearer picture of what it's like to study medicine at HIMSS and maybe even take away some advice for your own journey. So like most of you, I started off not really knowing what to expect. And the reason why I wanted to do this talk is because when I was applying or even starting out, I really valued hearing personal experiences. So it's not just about the academics. I want to share the real side of medical school, what it's like, what I learned, and how I've grown. So a quick overview of what I'll cover is I'll take you through each year at HIMSS, and then I'll talk about my elective placement and then a bit of reflections and advice. And at the end, I'll leave time for any questions you might have. So, phase one at HIMSS is your first and second year. And a lot of people ask me why I chose him. So for me, the main reason was problem-based learning style. It was very discussion-based, interactive, and it really suited how I like to learn. And here we also start placements quite early on. So I saw my first patient in the third week of first year. So because you see patients so early on, it's an amazing opportunity for you guys to build on your confidence and history taking and examination skills. And the school itself is quite small and personal. Everyone gets to know each other, and it's a very supportive environment. And you have placements across Yorkshire, so it gives you a good mix of city and rural medicine. So you have a good variety of experience. So your first year, to talk about my first year was an adjustment year, moving away from home, figuring out how to live independently. It's quite a lot at first, and I think my biggest challenge was probably managing the workload and figuring out what study routine works for me. But that's something that everyone faces. But I feel like if you have a good supportive network around you and helpful tutors, that really helps you overcome that problem. And the whole style of learning was quite new to me, but over time I really started to enjoy it. And I still remember my first patient encounter. It was quite nerve-wracking at first, but then it's quite exciting as well because you've worked up all throughout your school life to get to that point, and finally that day comes when you're a medical student. So, you realize that medicine is just more than textbooks. There's so much that you develop over time. And then in your second year, so I started feeling a bit more confident with history taking and examination. I felt more settled. You start spending more time in the hospital and at GP placements, and it brings all the theory together. So I started to understand how the different pieces fit in. So the anatomy, physiology, clinical science. And I also started to get involved in societies and do some teaching. So I taught my first group of students when they were in first year and I was in second year, and that was quite a nice experience. So I was trying to find that balance between academics and extracurriculars. So it was all about like building that confidence. Then we move on to phase two. So that's years three and four, your more the clinical years. So third year, it's quite a big turning point because you transition into full-time clinical placements and you spend most of your time in hospitals and GP surgeries, and you cover core specialties. So we covered psychiatry, renal, endocrine, cardiorespiratory, and you really start to feel like you're a junior member of the medical team, and you do a lot more of the hands-on things. So taking bloods, putting cannulas in, doing observations on patients. So it's also the time when you start to see what kind of doctor you might want to become, you because you get a lot of opportunity to shadow senior doctors. Fourth year deepens that experience, so you rotate around more challenging specialties, so pediatrics, neurology, obstetrics, gynecology, and um, I think I also started to narrow down my interests and finally came to the realization of what it is that I like, what it is that I don't like. It's quite intense, and quite honestly, the most difficult year out of all the 5 years. But you learn a lot, and by the end of fourth year, you just learn so much. And you get a lot of feedback, and you can reflect on your experiences throughout. So it definitely helps with your learning. And then year five, so where I am, the final stretch. So honestly, it has flown because I've already completed two rotations. So my elective is my was my first rotation, and then I did my GP placement for the last 6 weeks, 8 weeks. And it's all about preparing for finals and transitioning into your foundation years. And you get to shadow your foundation doctors in the hospital. It gives you a real taste of what's coming next. And also, you reflect on how far you've come and you realize that you're finally ready to become a doctor. So, in the next few slides, I've included some highlights of my HIMSS experience. There's been quite a few highlights. The friendships and community definitely stand out the most. Very supportive out here, and I had the opportunity to get involved in a lot of teaching, conferences, and societies. I've done quite a few testimonials, and I even made it to the front page of the university prospectus this year, which was something that I was quite proud of. And also placements across different hospitals in Yorkshire broadened my perspective on healthcare. And yeah, there's just been a lot of balance between medicine, socials, etc. But it hasn't all been easy. So there's been moments of stress, self-doubt, burnout closer towards exams. And I think one of the hardest things that I've had to do was manage my own expectations and not compare it to others. But every challenge has taught me something. And also, medical school isn't just about becoming a doctor, it's about becoming someone who can sustain a career in medicine. So, if we can just move ahead to the next few slides. So, I'm going to talk about my elective experience now. So that's something that I was really excited about, and I think most medical students are because it's the highlight of being a medical student. So for anyone who's not familiar, an elective is a placement that you undertake in some medical schools at the end, but at HIMSS we do it at the start of final year. And you can choose to go anywhere in the world and explore an area of medicine that interests you. So it's an incredible opportunity to grow personally and professionally, and also to sort of step out of your comfort zone and experience healthcare in a different setting. So I chose to do my elective at Cleveland Clinic in Abu Dhabi. So I was born and raised in the UAE, and my family is based there. So I just wanted to use the opportunity that I had during the elective to spend some time home. So I thought doing it in the UAE would be the perfect choice. And Cleveland Clinic is a very well-known hospital. And I chose to do it in emergency medicine because I feel like as I've spent time at medical school, I've sort of come to the conclusion that emergency medicine is what I'm drawn towards because I'm quite interested in the fast-paced environment and the incredible coordination between the team members. And I also wanted to experience healthcare in a different system. And Cleveland offers world-class facilities and learning opportunities, so I didn't want to miss out on that. And I got to observe and assist in the emergency department. So it was a 6 week elective. So I saw everything from trauma to cardiac cases, a very huge learning curve, things that I wouldn't have seen in the UK. And because the healthcare system is privatized there, I sort of saw that difference as well, how the patient flow, management of electronic record system works, etc. And it was truly an amazing experience. And I've definitely come back with better skills in assessing acutely unwell patients and trying to sort of navigate through a different cultural environment. And I could also generally see myself working in the emergency department and having a career in emergency medicine. So I was really glad for that. So in terms of my advice would be if you're planning your elective, you should start early on, at least 6 to 9 months. That way you have enough time to sort out your visa, paperwork, any vaccinations that need to be taken, and also getting a reply from certain hospitals can be quite a time-consuming process. So the earlier that you start, the better. And once you're there, make the most of it. Be proactive, ask questions, and it's a once in a lifetime opportunity. So also don't forget to enjoy yourself. So some reflections and advice now. So looking back, the person that I was in year one and the person that I am now feels worlds apart. And HIMS has not just shaped my medical knowledge, but helped me build resilience, my empathy, and confidence. And being a good doctor is not just about grades or exams. There's so many other skills that come along with it. And every experience from the late night study sessions to, spending long hours in the hospital, it's helped me grow into the doctor that I hope to become in a few months. So, my advice for current and future students would be that don't compare your journey to anyone else's. Everyone's path looks different, and make sure that you learn from your mistakes. They're honestly some of the best teachers. And medicine is a marathon, not a sprint. It's very important to look after your well-being. And don't lose sight of why you started in the first place, because there will be days where, things might not go the way you wanted to, but the passion that you have will carry you through those difficult days. And my journey has been challenging but incredibly rewarding. And I have found my voice, my confidence, and my purpose. And I'm really grateful for the mentors, friends, the patients that I've met who've shaped me along the way. And I'm really looking forward to the next chapter, so my foundation training, and quite excited for it. And thank you to Aspiring Surgeons Network for the opportunity. And that's the end of my talk. Thank you.
Thank you so much, Antara. That was like so helpful, even for me. And yeah, I just really hope that you guys enjoyed this presentation, this guest speaker event, because um, it's just really insightful to see like actual people that have went through this like medical process and what they feel, how they've improved. So yeah, if there are any questions, we can take them. Um, I don't think there are, but if there are any, could you please like just reply in the chat if that's possible?
Yeah, sure.
Yeah, thank you so much.
Thank you.
Thank you for coming again.
Thank,
It's really, really helpful.
thank you.
All right, can I please have Helene to do the hernia repairs, please?
Hi everyone, I'm Helen, and today I'll be talking about hernia repairs. So I would like to start off with what hernia disease is. It's a disease which is a common problem, and it's essentially when a bulge occurs, when an organ or tissue pushes through a weak spot in the muscular wall, and they can develop in various parts of the body. Um, Yeah, most commonly they occur in the abdominal or groin regions. Usually hernias are not dangerous, but they do require surgery to prevent serious complications. Next slide, please. So we're going to talk about the repair surgery, the techniques, outcomes, and the innovations. So a hernia occurs when, as I've mentioned, fat pushes through a weak spot in the muscle. Hernia repairs or herniorrhaphy restores anatomy and prevents recurrence or strangulation. And the most common sites are inguinal, femoral, umbilical, and incisional. And as you can see in the diagram there, it's where they're most commonly appeared. Next slide, please. So let's talk about the anatomy and the, I'm not going to try to pronounce that. The abdominal wall layers, skin, subcutaneous tissue, fascia, muscle, peritoneum, and then the weakness in the fascia or the muscle creates the herniation of the peritoneal sac, and the increased intra-abdominal pressure. So, for example, lifting or a chronic cough, obesity, it can worsen the protrusion. Inguinal canal anatomy is key for groin hernias. Next slide, please. So, indications of a hernia: symptomatic hernias, pain or a bulge. Strangulated hernias, they're more urgent. Asymptomatic hernias, there's an elective repair if at risk of complications or if your lifestyle impacts that. And it's more common in men than women. And heavy lifting occupations, post-surgery patients. Next slide, please. So before the hernia surgery, there is an assessment, so a physical exam and an ultrasound. And then there are labs such as CBC, coagulation, renal function. Again, those are just pre-op checks, which are done for most surgeries. And they will look at your weight, smoking, and your diabetes. And obviously, they will need consent, so they'll discuss recurrence and mesh use. And in the picture there are some other pre-op checks that they may do. So the procedure, it includes, so a patient is positioned supine under general anesthesia, and then you identify and expose the hernia sac. You reduce the herniated contents, reinforced defect with a synthetic mesh. You close the layers and dress the wound. And there are a couple types of kind of there's a laparoscopic bit, and there's another, I think it's on the next slide, so if you could. Next slide, please. So, there are a few types of surgeries which can happen. There's an open repair, incision over the hernia, there's a sac reduction, and then there's a laparoscopic approach. And then there's a robotic assisted repair. And in the diagram, like the picture, we can see that over 5 years, the mortality rate is much, so the survival rate is much higher for patients who had a laparoscopic surgery. So could indicate that laparoscopic surgery has better results over a longer period of time. Next slide, please. So post-op recovery, there's a hospital stay. I think, it could be a day case, or usually it's an overnight stay. For pain control, there are non-steroidal anti-inflammatory drugs or local anesthetic blocks. And then activity would be light walking for the first 24 hours, and then avoiding heavy lifting for the first 4 to 6 weeks. And then a full recovery can range from anywhere from 2 weeks to 6 weeks, and it depends, again, on the person, on the type of surgery you had. Next slide, please. So there can be some complications and risks, like every other surgery. The most common ones are bruising, seroma, and infection, which occurs in around 2 to 4% of patients. Serious ones can include recurrence, which happens in 1 to 10% of patients, chronic pain, 5 to 10% of patients, and mesh rejection, which happens in less than 1% of patients. And then laparoscopic risks include injury to the viscera or vessels, which again happen in less than 1% of patients. So they're much less common. Next slide, please. Outcomes and success rates. So open and laparoscopic both are effective. Laparoscopy, quicker recovery, less chronic pain, recurrence rates less than 5% for mesh, 10 to 15% for non-mesh surgeries. Patient satisfactions range from 85% to 95%. And alternatives to having a surgery are watchful waiting for small asymptomatic hernias, which could usually mean that, instead of having a surgery, it's better off to kind of not and just keep a good eye on it if it's asymptomatic. Next slide, please. So for the future, there are plans for biological and absorbable meshes, which I think are like being carried out already, and they reduce infection risk. There's a robotic hernia repair, 3D precision, faster return to work, enhanced recovery protocols, AI imaging for predicting recurrence risk. And again, that would be very beneficial in the future because you would know which patients to look out for and, again, reduce mortality rates. Next slide, please. I believe that might be the end.
Thank you so much, Helen. I'm going to be taking over now for the case study for Typhoid Mary. Um, and so Typhoid Mary was the first identified asymptomatic carrier in the US. So let's go over a little bit about who Typhoid Mary was and the person behind her. So her actual name was Mary Malone, and she was born in on 23rd September 1869 in Cookstown, which is in Ireland. And then she died on the 11th of November 1938, aged 69 on North Brother Island. And we'll be talking about North Brother Island soon as well. And she immigrated to the US when she was around 14 to 15 years old. And for her job, she was a domestic cook for wealthy New York families. So we'll be talking about families that were, like really experienced and wealthy bankers and lawyers. So she was a domestic cook for them. And essentially, she was the first person in North America who was identified as a healthy carrier, meaning asymptomatic carrier of the typhoid fever. And so her case revolutionized the understanding of asymptomatic disease transmission, and this obviously advanced how disease progression and disease like transmission is understood. And her name became like synonymous with the disease carriers. Okay, typhoid fever is basically a bacterial infection caused by Salmonella typhi, which is a type of bacteria. And you might have heard of, the infection called Salmonella, and this is quite similar to Salmonella in a sense that it's spread through contaminated food and water. And the transmission is fecal to oral route, which means that the pathogens in fecal matter are ingested. So this usually happens if you don't have very good hygiene, like you don't wash your hands while you're, touching food or you're cooking, which does link back to her occupation. So we'll be talking about that a little later. And so symptoms for typhoid fever are very, very high fever, which is about 39.4 to 40 degrees, severe headaches, and abdominal pain and cramping, diarrhea or constipation, loss of appetite, just general weakness, um, and rose-colored spots on chest in some cases, and delirium in severe cases, which basically is like a confusional state where you just are confused and you don't really know what's happening around you. So, historical context for typhoid fever, obviously, this was before the 1940s, so there weren't any antibiotics available because penicillin became widely usable in the 1940s. And typhoid fever is like fatal in approximately 10% of all cases, and it's common in crowded and urban areas. And it's associated with poverty and poor sanitization, which does link back to how it spread through contaminated food and water. And around in 1906, New York City reported 3,467 cases and 639 deaths. So it is a really widespread fever and disease that you could get back then. Asymptomatic or healthy carrier. So what does that mean? Essentially, it just means that you carry the disease in you, like you have the disease, but you don't express it in a sense. You don't have any symptoms for it. And so this was a revolutionary discovery because this concept was unknown in 1907. And so the first healthy carrier was identified in Germany in 1906, which is 1 year before Mary's case. And so scientists were just beginning to understand this phenomenon. And so her case kind of reinforced the idea of asymptomatic carriers. And that's how now we have a better understanding of disease transmission. And up to 6% of typhoid patients can actually become long-term carriers. So it was quite common back then. But Mary's case was obviously more like severe in a sense because it was publicized by the media more. And so where does the bacteria hide? Essentially, what I mean by hide is why is it not expressed? Why is it not, in some patients, why is it not expressed? And why are they asymptomatic? So primarily the bacteria hide in the gallbladder, and it can also reside in like intestinal or mesenteric lymph nodes. It's also called mesenteric and spleen. So essentially, intestinal and mesenteric lymph nodes and spleen, essentially what they are doing, they are very important immune, like they help the immune system in a sense because spleen stores and filters blood for like any worn out or damaged like red blood cells. And gallbladder is also very important in the immune system. And the bacteria can be integrated into immune cells. You might have heard of macrophages, which is essentially a type of white blood cell that can engulf bacteria and digest it. And it is part of the primary immune system line. And it's the bacteria is shed continuously in the feces without it affecting the person, and it can remain for life if untreated. So the incident that started everything. So in 1906 in the Osterbray. So in summer of 1906, Mary was hired by Charles Henry Warren, who was a wealthy banker, and in August 27th, around August 27th to 3rd September, 6 out of the 11 household members fell ill, which included Warren's daughter and several servants. So this the breakthrough was that Mary Malone arrived on the 4th of August, 1906, and then 3 weeks later, the typhoid was broken out, and Mary was preparing fresh peach ice cream. It is quite synonymous with her name, and like um, the case study that I made, this was it was quite recurrent, and a lot of the articles I used talked about the fresh peach ice cream, and essentially. The gentleman over here, which I've included a picture of, his name is George Soper, and he was investigating this case, and he realized that uncooked food and the poor hand hygiene that Mary had was the perfect like equation for the typhoid fever transmission. So his investigation, so first he started off by tracing Mary's employment history. So for the past decade, he contacted employment agencies that placed Mary and discovered that 7 of the 8 families Mary worked for in the past decade experienced typhoid outbreaks. So she worked for 8 households, and 7 of those households had typhoid fever, and like they were transmitted the typhoid fever. And you can see here we have about this is like confirmed-ish data about how many people she did actually infect throughout her lifetime, not just while she was working. Uh, but about 51 to 122 people uh, have been estimated to be infected across multiple households and multiple hospitals as well. And there were 3 confirmed deaths as well, though some estimates suggest that there were as many as 50 deaths in total. So Soper then confronts Mary by locating her in Park Avenue, Brownstone, Manhattan, and that's where she was working. And already there were 2 household members that were already ill. Um, and so in March 1907, so Soper then approached Mary in the kitchen of that house and requested samples of her blood, urine, and feces to, check if she had typhoid fever. But then Mary obviously said that she has never been sick with typhoid because she never ever like experienced any symptoms. And then Soper actually did quote this, where he said, seized a carving fork and advanced in my direction. So this describes Mary as being very hostile after Soper like approached Mary, and she reportedly chased him onto the street as well. Soper continued to stalk her around Manhattan. He even located her boyfriend's house to try and persuade her to give her samples, but she refused again. And then he even tried to collect her samples secretly, which is a little weird in today's context. And then Soper reported these findings to the New York Health Department in 11th of March. And because of this, Mary was deemed a public health threat, and an arrest warrant was issued. So then Dr. Sarah Josephine Baker, which I've put a picture up of, she was assigned to arrest Mary, and she brought up like five policemen for backup. And then she went to Mary's house and found her hiding in a closet under the stairs. Um, and so Mary fought violently, like being in a cage with an angry lion. So she was quite hostile while they were trying to arrest her. And Baker had to physically sit on Mary in the ambulance to restrain her. Um, and yeah, so Willard Parker Hospital, so that was the hospital she was forced to give blood and urine and feces samples. And she was not allowed to use the toilet alone for 4 days because they needed the samples to, check if there was any, typhoid or Salmonella typhi bacteria. And there was a pure culture of typhoid in her stool, and massive amounts of Salmonella typhi bacteria was also found. And then Mary actually confessed, and she said that during questioning, she confessed that she almost never washed her hands, and this was not unusual back then because germ theory was still not widely accepted. And then first quarantine, so North Brother Island, so that's where she was transported to in around 1907. So this was known as a quarantine hospital, and it's still synonymous with this case. And so this facility was the Riverside Hospital. And she was required to give stool samples 3 times per week. Most tests came back negative for typhoid when she was actually in. Uh, sorry, just a second. Okay. So then she was put in for three years. Um, in her quarantine. And this obviously had a psychological impact. She suffered a nervous breakdown after arrest, and she actually wrote letters proclaiming innocence and saying that she's never had typhoid in her life and that she's always been healthy. And she described herself as a kidnapped woman, and she was obviously growing bitterness toward the medical establishment because she wasn't like informed about her effects on just leaving her in like society. She wasn't educated on the fact that she may have been asymptomatic, and that she has typhoid, but she just doesn't express any symptoms. So then there was a legal battle in 1909 where she tried to sue New York Health Department, and this case was brought to the New York Supreme Court, and the press coined the nickname Typhoid Mary, and that's really, really well known now. And then this lawsuit was dismissed because the laboratory evidence was too strong, and media published like sensational illustrations. So, as I've put on the picture, a woman tossing skulls into a frying pan. So this case was quite publicized by the media as we have looked at other previous like case studies. It's quite similar. The media does tend to publicize these type of case studies, and that's how they become widespread. And so there was a change in policy, which was instilled by Eugene Porter, and he was a New York State Commissioner of Health. And so he decided that you can't really like quarantine all healthy carriers because there were hundreds that existed. And so there was a new policy that released carriers. Uh, you can release carriers who promise to take precautions and just, like act on the terms of release that they have been put in for. Um, and so there was a focus on those in food handling occupations, especially because of typhoid fever and how it's transmitted. So there were terms of release for Mary as well. Mary never, so the terms of release were that Mary never works as a cook again, and that she has to change to a different occupation and take reasonable hygienic precautions, and she has to report regularly to the health department, and she needs to avoid transmitting typhoid to others. And so she signed like a contract agreeing to all these conditions. And then, so she did try to, search for different occupations. She tried to, but she didn't get any. And she couldn't sustain herself on just low-wage domestic work because it wasn't paying her enough and it was quite hard for her to survive. So then she decided to use false names to avoid detection and continue to work as a domestic cook. So she worked in hospital, sanitariums, hotels, restaurants, and institutions. And Mary may still not have believed that she was actually truly dangerous because she wasn't educated about her case and how she was asymptomatic. So then the Sloan Maternity Hospital outbreak. So then she started working in the Sloan Maternity Hospital. And so there was a major typhoid outbreak because of this. And 25 workers were infected. So this included doctors, nurses, attendants, and staff. There were two deaths, one nurse and one chambermaid. And so then an investigation by Dr. Logan was led. And so he then initially examined water supply to check if it was safe and if it wasn't contaminated. And then it was safe. Then he focused on food preparation. He then examined staff. So he examined the cook, and then found that there was a female cook who tested positive for typhoid, and then the staff jokingly nicknamed her Typhoid Mary, didn't actually know that it was actually her. And so then Officer John Bevins recognized her from years before. So essentially, what she did was that she kind of escaped when she heard that there was a typhoid outbreak in her work of place. And then so Officer John Bevins then checked hospital records and saw that the cook's name was Mary Brown. So obviously it was a fake name. And then the address given was private house in Corona, Queens, but she was living in Long Island. So then, after she was arrested and she was returned to quarantine for life this time, so this was a life sentence on March 27th, 1915. And so this lasted 23 years until her death. So it was a life sentence. And so the total time she was quarantined, so the first and second times, she was in quarantine for nearly 30 years of her life. But then she was granted unaccompanied releases to walk the island. But obviously this wasn't the same as living just a normal human life because she did spend like half her life in quarantine. So then during this, her health started to decline. So she suffered paralytic stroke. This was likely in the mid 1930s. And her final years were her in declining health. She developed pneumonia and died on the 11th of November 1938 when she was aged 69. And the autopsy revealed that there was still live Salmonella typhi bacteria still in the gallbladder, so she did remain a carrier her whole life. So her impact was obviously quite big. Confirmed statistics were that 51 to 53 people were infected, and these were confirmed cases. Then there were three confirmed deaths. Some estimates suggest that there were about 122 infected cases and 50 deaths, but this is unconfirmed. She used multiple fake names, so the true numbers and her true like impact is still kind of unknown. And there was a 15-year period of active transmission while she was out on the loose. So then scientific contributions were that she was the first identified asymptomatic carrier in the US. She advanced our understanding of disease transmission and also her case led to the identification of 400 plus other carriers by 1938. And this also changed public health policies nationwide, but also worldwide. And it influenced quarantine and isolation procedures as well, which we continue to use to this day. It also enhanced food safety regulations in as well. And then, so was the quarantine justified? So this is a running argument. So there are, pros and cons to this quarantine. So obviously the arguments for are that it protected public health because if we let her in the loose and if she was to, just live freely, typhoid has 10% mortality rate, so she could have, infected hundreds of people and caused many more deaths as well. There were no antibiotics available to treat her back then, so she couldn't have been treated, so she did need to be quarantined to prevent any further transmission of infections. She repeatedly violated terms of release. She returned to cooking despite knowing the danger, but I would argue she didn't know the danger because she wasn't educated about it. And also showed no remorse or willingness to change behavior. And gallbladder remover was the only cure, but this was risky and she refused, which is in her rights. Arguments against is that she violated this quarantine violated individual civil liberties, and that she didn't really commit a crime. She didn't intentionally harm anyone, and she may not have known truly understood why she was dangerous. There were other carriers, about 400, that were identified, but they weren't quarantined either. And so this raises the question of why only Mary? Why was Mary only confined and quarantined? And she could have been monitored and educated instead. And forcible lifelong detention without trial is quite unjustified. And gender, class, and ethnic bias also might have played a role into her quarantine. So obviously, I was talking about the double standards. There were by 1938, there were about 400 known asymptomatic carriers, and they walked around freely without quarantine in NYC. So one of them being Tony Labella, and he was a German immigrant and also a food worker. He might have infected. He has infected 100 plus people and caused 5 deaths, and he was still not quarantined. Frederick, who was a German confectioner. He also infected more than Mary, but he was forgotten by history and just wasn't quarantined. And so we do notice a pattern here that male carriers were generally treated with more leniency. So, some factors that may have played into the double standards were the fact that she was a female, she was Irish. Back then, Irish people were a marginalized group. She was poor, she didn't have any resources to fight back. She was uncooperative, she was quite stubborn, she refused to comply, and she was single, so there were no family to advocate for her. It might have also been because the fact that she was first identified, and so she was used as an example essentially. So obviously she couldn't be cured because penicillin was discovered in 1928, but wasn't widely used until 1940s. And there was a surgical option, which was gallbladder removal, but this had a very high mortality rate and it was deemed very, extremely dangerous. And the anesthesia and antiseptic techniques were also quite primitive back then, so she did refuse surgery, and there was still no guarantee that the surgery would eliminate the bacteria. So, in terms of modern understanding, bacteria can integrate into immune cells. So even after the surgery, maybe there was a chance that the her macrophages may still have contained the typhoid fever bacteria. And it can reside in multiple locations. So it can reside in the gallbladder, lymph nodes, and spleen. So you can't really remove all of them from a surgical perspective. And genetic mutations may allow bacteria to hide undetected. And even today, there are some carriers that are difficult to cure even after the modern technology that we have available. So, yeah, that's why she couldn't be cured. And so we do have lessons from this case. The fact that importance that there is a really good importance of like asymptomatic carriers because you can't really rely on symptoms alone. So COVID-19 demonstrated this dramatically. There were quite a lot of asymptomatic patients that didn't, express any of the symptoms, but they could still transmit the infection. They could transmit the virus. And so the second point is that communication is critical. So Mary may never have fully understood her condition, and there was a mistrust and resistance that resulted from this. That no one really educated her about her condition, and people do think that building trust may have been more effective than just using force. And equity and justice matters. So obviously there were a lot of patients and carriers that were identified, but those standards weren't applied fairly and consistently. Um, and that's why equity and justice and those type of laws and just ethics apply to every patient, every asymptomatic carrier, because just being a woman or just being Irish doesn't really make you more of a asymptomatic carrier. And so here are some sources for wider reading if you're interested in this case. And I want to hand over to Mufassir so then he can talk about the academic essay for the ASN essay competition.
Hi, hopefully you can hear me. Yeah. So, hi everyone. I'm just going to go through going to do a walkthrough about what's involved in writing an academic or research-based essay. And you'll be asked to do quite a few of these in medical school. We can do it for your EPQ, and you can use some of these tips for the essay competition that we're currently running. So I'm just going to break down the main types of essays you can write, how to structure them, critically analyze sources, and then just go through some main tips. So these are some examples of academic essays you'd be expected to write, and you can probably get these published as well. So a case report is basically presenting a rare or novel case and their management. So this should highlight unique clinical features or decision-making processes. So think about cases beyond common conditions. So for example, one that I did was a patient who had diabetic ketoacidosis. And with further investigation, we found that there was adrenal insufficiency, and that was due to an unnoticed background of a very rare autoimmune condition called APS type 2. Um, so you don't want to do it on something very broad like someone had a stroke. It should be quite specific. Critical appraisals, that will basically involve a systematic evaluation of a published paper. So you look at one paper and you focus on the validity of the results, the methodology used, any strength, limitations, biases, etc. A literature review is the most common type of essay you will write. And this is what's sort of relevant to the ASN essays. So you want to summarize and compare multiple studies to answer a specific question. A systematic review or meta-analysis, they are like the best type of researches, or the most common as well. So they involve synthesizing high quality evidence using sort of a set criteria to come up with a sort of a robust conclusion. So general structure of an essay, you want to have your title as your cover page, and you want to have an abstract. So this will probably be quite new to some of you. That's basically just like a summary that's clear and accessible to non-experts. So everything should be written in lay terms. And you also want to state your aim, your methods, and your key findings. It should usually be about 500 words. Then you go into introduction. So you're basically providing a background. So explain why a topic is important, present key literature, identify sort of what's missing or unknown, and then set out clearly what your research question is. So what's your objectives? Then the main body is where you're going to explore your evidence and arguments. So this is where you're going to be comparing and critiquing your studies. And then your conclusion is tying everything together. So present those key findings, the significance, any limitations, and what next steps for research are. I think I put in an example. Yes. So on the right, this was how I structured I think this was a case study I did. And on the left was a literature review. So I'll just focus a little bit more on the introduction, what you should write. So as I mentioned before, you want to outline relevant background. So why does this topic matter? You can look at epidemiology to help you out. So whether this condition is prevalent, what's the mortality rate like? Is there any specific social or financial burdens on the healthcare system? And then you want to present so what's already known from literature. So you can use the NICE guidelines to help you out. So if you're doing diabetes, look at what the modern day diagnostic criteria is and treatment methods like metformin, insulin. And then where are the gaps? So is there certain types of patients that there's no treatments for? And then you want to clearly state your aim, or your research question. So start with a broad view, so a global perspective, and then narrow down to your focus. So you're setting yourself boundaries so you can avoid excessive description. So are you focusing on the UK healthcare system? Are you focusing on a specific age group? Or something like that. Next slide. Did I put yeah, I put some examples. Okay, so on the top left here is basically an abstract. So you can see everything's written in lay terms. Conditions are all defined out, so anybody can read it and understand it. And then everything else is just a bit on introductions. So you can see here I've been talking about what the modern day literature involves in diagnosing. I think this was for gestational diabetes. Yeah. Next slide, please. Okay, so the main body, this is where you're gonna be, so you've gone from reporting facts and now you're gonna analyze and evaluate. So if you're doing a critical appraisal, you wanna ask yourself, is this study reliable? So what were the methods used, the sample size, any control variables? There's certain frameworks you can use. So I liked CASP, which is basically this online critical appraisal checklist you can use. You'd use this for other essays as well. So checking if the paper has used the correct sort of statistical tests for the data, and were the results proven to be significant, and were they properly reported. So you can look at whenever you're reading a research paper, when you go to the findings or the results, there's always going to be some stuff about p-values and confidence intervals. You always want to mention that in your essay. That will show if the results were significant. You want to check strength and limitations. So again, sample size, the type of design study, any biases, generalizabilities, did they exclude important groups that may have affected the results? And is it applicable to real life practice? So can we use these results in the NHS? You always want to compare studies. So if you find conflicting results, discuss why. So look at the methodology. Was it stronger? Look at when the study was done. So older studies usually have outdated methods. And then you want to use critical language when doing this. So if this is a marked essay, you're going to be very clear and use language like, however, a systematic review showed this, or conversely, blah, blah, blah. And this will help sort of present alternative interpretations. So gain different viewpoints and explain which one you support and why. And then always give you insight as well. So how are these findings going to affect different populations or clinical settings? And does the wider healthcare system need to make a change? It depends what your research question is. Just focus a little bit more on how to critically analyze sources. So you basically want to start with the methods. So how was the study designed? Was it a cohort study? If it was it prospective or was it retrospective? Was it a cross-sectional study or was it randomized control? Is the population appropriate? Did they include all the age groups, all the different types of gender, sex, etc.? Sample size as well. Is it adequate? Did they use were ethical, differences in cultural and ethnicity backgrounds taken into account? Were certain groups included or excluded? Look for biases. Look for attrition bias as an example. So patients usually drop out of studies, especially if it's done for a long time, and would that have affected the results? Look for any conflicts of interest. So every single paper you find online should have information on who funded them, and they should declare the conflicts of interest. So I'll go through an example. If there was a cross-sectional design, those usually can't determine causality. Retrospective studies, they have a lot of bias, so they can suffer from recall bias. If a study has a small sample size, then that limits generalizability. You want to also look at the control variables and any unmeasured variables. So those are your confounder variables. And did the results adjust for that? Those are usually the biggest thing a lot of research papers will miss out on. You want to also learn how to spot red flags. So were there poor controls used? Was there selective outcome reporting? And most of the times, actually, you come across papers that only one part of the findings is actually relevant to your topic. So if you're using that study, if you're referencing it, just compare the context and explain the relevance to your question. Yeah, okay. I think I'll move on to conclusion then. So how do you end this all? You want to basically summarize your findings that are applicable, and you don't want to add new references, so you shouldn't be adding new sources. Have I skipped on? Am I okay? Let me talk about ethical and reflective writing. Actually, okay. Um, so if you have an ethic-based essay, if it's like a case report, you want to make sure, did you respect the patient's right to make the decisions? Were they given all the information? Was there informed consent? If you're looking at a new treatment option, is this paper acting in the best interest of the population? What benefit does your findings or results bring? So you always want to do sort of like this benefit risk analysis. And you want to look, are your findings going to be allow equitable access? So could we actually use it in the NHS for everyone? Okay, the next slide. So how do you find reliable sources? So don't use things like Wikipedia, don't use social media. British Medical Journal is really good. So BMJ, nice guidelines. PubMed, you can use like WHO or the NHS official website. High quality randomized controls are really good. Systematic reviews and meta-analysis are very good to use. You want to avoid citation dumping when your references. So don't use lots of them. Use references just to build your argument. And it's okay if you want to use the same reference 3 or 4 times. That's absolutely fine. And when you're interpreting figures and results, explain what the data actually shows and how it's going to affect your argument. Don't just put that image in there and not explain it. You can use sort of AI as well. I think, did I put that in there? Yes, okay. So, I mean, everybody's going to use AI these days for research. So good examples, ChatGPT most common. There are others like Perplexity, Cite AI is quite good. Use them to summarize literature and maybe help you generate insights or suggest a framework for you to use. Don't copy and paste. Use your own critical reading skills. And ChatGPT is not always accurate. Sometimes they can use primary sources, so it's not great. If you want to use a search engine, Google Scholar's a good one to use. So you can put keywords in there, sort by dates, type of papers, etc. Because all the essays you do will go through a plagiarism detector. So I'll talk about, I think, referencing. Yes, okay. So at the end of your paper, you're always going to have a bibliography or reference page. You want to stick to a certain style of referencing. So most commonly, it's Harvard referencing. That's the one I'm most familiar with. There are other ones like Vancouver method. Just use what's best for you. There's no correct method. There are certain online websites you can use that do a bibliography for you. So you just put the link of the journal in there, and it'll put the author and the sort of published date and everything. So Cite This For Me is a very good one. There's other ones like Mendeley or Zotero. But if you do use these online websites, or if you use ChatGPT to reference, make sure you go through the DOIs. So double check, has this reference linked to the correct journal? Because sometimes it gets it wrong. And when you're doing in-text referencing, you can use footnotes or endnotes or in-text citations. Footnotes usually work best if your essay is really long, so more than about 5,000 words. If not, in-text citation is fine. Next slide. Okay, so just a bit final tips. Try to avoid jargon. If there's key scientific terminologies used, define them, explain what they mean. Don't make your paragraphs long, so break it up. So you don't want one page to be a whole paragraph. Double space it, so just easy for people to read. And proofread everything. Um, Biggest final advice I can give you actually is always get someone to read over your paper so you get a different insight. Um, if you can, try to get a clinical supervisor to read it. If not, a friend is fine. I think that's all. If you have any questions about writing essays or a specific research paper in general, just put it in the chat and I'll answer it. Thank you.
Thank you so much. Can I have Silver now, please?
Yeah, so we're going to go through interviews now. So this is basically just going to run through ethics and ethics mostly today. But in terms of ethics, we're going to be looking at some key things that you can use, and that's knowing your four medical pillars of ethics. So patient autonomy, non-maleficence, justice, and beneficence. And then we have other definitions next to it. So we're looking at patient autonomy and looking at ethics. You want to see, does it show respect for the patient and their right to make decisions? With non-maleficence, you want to see, does it cause harm to your patient? Justice, are there consequences in the wider community? And then beneficence, and that's, does it benefit the patient? Okay, some key resources that you can use, and I definitely did use these in my interviews, is GMC Outcomes for Graduates and the GMC Good Medical Practice. The Good Medical Practice was updated, I think, last year as well to be more in accordance, so it's a really good resource to use. But the GMC Outcomes for Graduates just displays the main NHS values that the GMC expects from doctors, and the Good Medical Practice outlines the GMC's expectations for practicing medicine and can be really good in discussing for ethical questions. Now, in terms of the four pillars of medical ethics, again, we have justice, autonomy, non-maleficence, and beneficence. But some extra things you may want to take into account when answering these questions, especially if you were to apply to Oxbridge, is utilitarianism and consequentialism, which is focusing more on what do people focus on when deciding how an ethical outcome can be. So these are different ethical scenarios that you can use. So utilitarianism focuses more on who's it going to help, the focuses more on what you're doing in the moment, like what your actual actions are, while consequentialism focuses more on the consequences of the action. So it's looking at what people put more effort and more focus on when making a decision. Okay. Now, a four-step process to answer medical ethics questions is briefly explaining why it's a difficult topic and why it's commonly debated, then explaining the rationale behind one side of the argument. You must use the medical ethic pillars of autonomy, beneficence, maleficence to give a justification for your answers. They usually do have this on the mark scheme for a lot of universities. And then explaining the rationale behind the other side of the argument and reaching a justified conclusion. And you're also giving your own opinion, but you don't have to give your opinion if you're not really stated for it. I usually stayed in the middle of the argument if I didn't have a sure buyer opinion, so it depends. And if added, you can also summarize the previous points if you have more time to answer the question. Okay, now in terms of hot topics are things that have happened recently in the field of healthcare that are worth knowing for your interviews. The word hot topic can be a bit of a misnomer, as a few things we'll discuss today have been for a while. I've actually been around for a while, and just because a topic isn't recent doesn't mean that it isn't going to be asked in interviews. For example, can also refer to hot topics in appropriate stations. If a station is about time management, responsibility, ethics, so any of your general questions, you can still refer to hot topics to actually justify your answer. You can refer to topics or an example within healthcare that you think is appropriate. The list isn't prescriptive, and obviously new things are happening all the time. So I definitely think you should keep looking at the news and reading up on things that do interest you. And there's also a really wide range of topics that you can use to fill out a short interview topic. But I'll go through some examples. Okay, now in terms of hot topics, there's two different types of hot topics you can really get in terms of how the question is asked. So they could directly ask you about a topic, for example, obesity in the UK, or they could ask you a generic question, for example, tell me one core issue you think is the NHS is going through. So it's more focusing on how you want to answer the question that's being asked. We can go to the next slide. So an example question is question 1. A 25-year-old man has tested positive for HIV and does not wish to inform his partner. What might you do if the patient had a contagious infection and tells you, but they have not disclosed this to their partner? I'll give everyone a minute to maybe put any opinions they have in the chat and then just how they think they'd approach the question. Okay, so we didn't get a lot of opinions on that, but some key factors you can consider is patient autonomy, and looking at the idea that you don't need to tell your partner if you don't want to, but also looking at the idea that you need to protect your patient confidentiality, and then also looking at maleficence. So basically just working through the medical pillars to see what are some core issues with this question, and also thinking about your opinion overall, and actually seeing how does that link to the GMC. For example, in the GMC guidelines, it may tell you how you should approach the question. So actually focusing on looking at, I could actually read the GMC outcomes to see how they expect me to answer this question and seeing things like that. But also looking at just different aspects you can take to answering the question. But yeah, with sexual health, it's really important to maintain patient privacy, as many will report feeling embarrassed or targeted because of their condition. So basically taking into account all the different aspects that could happen regarding this question. The next slide. Okay, so question 2 is another type of ethics question, but I think this could also be a role play question, but still focused more on the ethics of it. So it's towards the end of a busy shift. You've just witnessed a colleague making a mistake with a patient's treatment. What would you do? So this is looking at ethics, but also looking at how you would handle this type of situation. So it could be a role play scenario, or it could be a simple wide-ended question which asks, what do you do? And then those are the two ways they can kind of ask this ethical question. And it's more focusing on how you're going to prioritize and how you're going to sort out the issue. Obviously, you have seen someone making a mistake, so the best thing to do would also be looking at how you're going to approach them, how you're going to start with it immediately, but also taking into consideration that this is your colleague, so maybe you want to speak with them first before straight away going to someone who's higher. So actually just making sure you do have a pattern of how you want to approach the situation, because it is towards the end of a busy shift. So you also need to take into account all the different things that are happening. So it's towards the end of a busy shift. Does that mean you're tired? You don't want to deal with the issue? What's happening? And actually approach the fact that even though I am tired, I may escalate this to my manager just because we are closing up, and I do want to make sure that the colleague does know that this is a mistake and it shouldn't happen again, especially with it being a patient. But you could also look at the fact that it is a patient. This could be something that's urgently affecting their care. So just looking at all the different things that you can talk about. There isn't one right answer. It's more of a really wide spectrum answer. So you need to focus on all the different things you can use to answer the question. The next question. So this is a hot topic question. So why is the NHS under pressure? As you can see underneath, there's a long list of so many different reasons why the NHS can be under pressure. You can have A&E pressures, focusing on specific aspects of the NHS, A&E pressures, GP pressures, aging population. You can also look at other things that have been in the news, so using other NHS hot topic questions, hot topics to answer this question. For example, using the NHS long-term plan to actually see some of the key issues that are in the NHS that they're actually trying to solve, and say that's one of the reasons the NHS has been under stress. You could look at a biopsychological approach to it. You could look at some of the key issues, some of the core issues, some of the economic issues that are affecting the NHS. It's kind of just figuring out how you want to answer the question and using a range of different answers to actually focus on your key point. Some people do like to just focus on one point, but I think it does depend on how much research we've done on the question. For example, I think NHS under pressure, there's so many different things you can talk about that you might want to focus on one key point and just evaluate that, just because you do have a lot of time and a lot of knowledge on that one topic. But if it was a more niche question, you may want to focus on just going through different points, as it means you're going to just be able to expand and speak for the whole amount of maybe 3 to 10 minutes, depending on the university you're doing your interview for. But yeah, next question. So question 4, I don't know if anyone will answer it in the chat, but this question is: do you believe NHS will last another 100 years? Now, this falls under hot topic questions, and it's one of those questions where no one really knows what the answer could be, but you can use all your past knowledge on hot topics to answer this question. For example, looking at the economic status of NHS, looking at privatization versus standardization in terms of another NHS hot topic, and using all of these reasons just to focus on why you think NHS will or will not last. You can actually use the idea of other healthcare systems in other different countries and seeing how maybe NHS might try and adopt those types of healthcare settings, healthcare systems within the country rather than focus on the NHS. And also looking at what's the significance of NHS. Basically, it's asking for your personal opinion. So do state your opinion, because that is really important. So a yes or a no, but also give the other side of the argument, because they do want a balanced answer. So as it did say before, focus on one argument, then move to the other side of the argument, and then give your final conclusion and your final opinion on if you believe the NHS will last another 100 years. But yeah.
Thank you so much, Silver. Can I have Neha for this final part of the seminar, please?
This month is Breast Cancer Awareness Month. Each year, around 55,000 people are diagnosed with breast cancer in the UK. It is more common in people over 50, but it can also affect younger people as well. So, breast cancer begins when the breast cell's genetic material has a mistake, causing it to grow and divide uncontrollably. This eventually leads to a formation of a tumor. Breast cancer can start anywhere, but most frequently begins in the cells lining the milk ducts or milk-producing glands. It can be non-invasive, where it stays within the ducts or lobules, or invasive, where the cancer cells spread outside of where they first started. The most common symptom of breast cancer is a lump or thickening in the breast or armpit. Other symptoms can include a change in size or shape of the breast, skin dimpling or redness, nipple changes like inversion or nipple discharge, a rash, peeling, or scaling of the skin on the breast or nipple can also be a symptom. Anyone can get breast cancer, and the cause is not always clear. You are more likely to get it if you are, for example, like have dense breast tissue, have other people in your family who've had breast or ovarian cancer, have breast conditions such as Benning breast disease, or have high levels of hormones. You cannot always prevent breast cancer, but going for breast screening when invited can help find cancers that are too small to see or feel. You may be eligible for a genetic test if any of your close relatives have had breast or ovarian cancer. This genetic test checks for faulty genes that increase your risk of getting cancer. For example, a faulty BRCA gene. If breast or ovarian cancer does run in your family, it is advisable to speak to a GP, who may then refer you to a specialist breast clinic or genetics clinic for assessment if you are thought to be at increased risk. If you're 18 or older or have one or more Jewish grandparents, you may also be eligible to have NHS genetic screening for faulty BRCA genes. If a GP thinks you have possible breast cancer symptoms that need investigating or abnormal breast screening results, you may be referred to a breast clinic. So at the breast clinic, you will have more tests and scans to check for breast cancer or other breast conditions. So these may include an examination of your breasts, a breast x-ray, an ultrasound of your breasts, or taking a small sample of cells. So this is known as a biopsy. So usually using a needle to test for breast cancer and look for certain proteins in the breast cancer cells, which can help decide which treatments are best. The treatment for breast cancer depends on the size and type of breast cancer you have, where it is, if it has spread to other parts of your body, and also your general health. So, surgery for breast cancer can include removing only the area of your breast with cancer in it, removing the whole breast, or removing lymph nodes in the armpits. So, lymph nodes, they are small glands that are part of the body's immune system. And then you also have radiography, which uses radiation to kill cancer cells. So you may have this when after surgery to lower the chance of the cancer coming back, or if you have secondary breast cancer to help control your symptoms. And then you also have chemotherapy, which uses medicine to kill cancer cells. So you may have this when before surgery to help make the cancer smaller, after surgery if the cancer has spread to your lymph nodes or is growing quickly, either before or after surgery if you have certain types of breast cancer, and if you have secondary breast cancer, to help make the cancer smaller and control your symptoms. There's also hormone therapy, which uses medicines to either lower the amount of certain hormones in the body or block certain hormones from getting to breast cancer cells. And you also have targeted medicines and immunotherapy, which helps your own immune system to kill cancer. I wanted to finish this presentation off by letting you know about some national cancer charities that can offer support and information about breast cancer. So we have Breast Cancer Now, Macmillan, Cancer Research UK, and Marie Curie. So thank you so much for listening to my presentation, and I hope this has brought some more awareness to breast cancer.
Thank you so much, Neha. Thank you for the people that stayed behind and listened to the presentation. I hope you enjoyed this week's seminar. It did run a little bit over. But yeah, here's the attendance form for the people that stayed. And yeah, thank you so much for joining, and I'd be glad to hear your feedback for this seminar. Thank you.